for men, also for somatic complaints. In our culture, men are known to go to doctors with far more delay. And this also reflected here that the rate of women with mental health problems or disorders who had never sought help were lower than that of men in all stages, whether they had just mental problems or whether they already fulfilled a current Axis 1 disorder. But again, if you had looked, and these were all current problems and current mental disorders, the rate of those who actually fulfilled, there is a pointer, who actually fulfilled a mental disorder criterion. Here, the rate of women was even lower than that of men in terms of currently being also in contact. So that was quite a surprising finding, that although they had a lower number in never having sought contact, the current contact was far more frequent. So it seems that a lot of these treatments had not been prolonged sufficiently long, because they still had mental disorders and were frequently discontinued. When we looked at the different mental disorders or problems and their contribution to current help seeking, we found that it was in particular the number of mental problems. So the more mental problems you had from various domains, so for example, from the affective domain and the anxiety domain, then you were more likely to seek help. And in particular, if these problems led to a functional deficit. So here in this pathway model, a functional deficit was really the crucial thing that led to help seeking. The more impairment there was there currently, the more likely people were in current treatment. And also in line with literature, those who were misusing drugs or were drug dependent were far likely to not seek help. So having a drug abuse dependence reduced the likelihood of seeking help, while for all other disorders, there was a significant contribution, in particular here for anxiety disorders or problems, and post-traumatic stress disorders and problems, and if there was a somatic contribution to the mental problems. Furthermore, it was shown in the model that having no current partners, so being single and to be older, increased the likelihood of current help seeking, and of course also past help seeking. So if you look at the contribution of past help seeking, that was not higher than, for example, here age or current partnership. It was actually really current functional deficits that mainly contributed to help seeking. And when we had looked at males and females separately, then the past treatment was only relevant for the males, while the higher age and the status of being single was mainly relevant for the females. And if we put that together with the main self-reported reason for help seeking, then these results fit in very well. In our Pathway to Care questionnaire, we also had an open question saying what were the problems that you were seeking help for, and the most significant share of problems that were reported as being the problems that led to help seeking was depressive mood. Next then were partnership and familiar problems that of course would also reflect on the level of current functional, psychofunctional degree. And then next to that, it was anxiety. So these were by far the most frequently given reason why people would seek help. And this is also in line, at least for other Western countries that report that no matter what the real problem is, that these three contributors, a functional decline, especially in social functioning, a depressive mood, and in great anxiety, nervousness, tension that all goes there together, are the main reason for seeking help, or why someone else is advising help. Are there questions or comments at this point?
Bapak Ibu, barangkali ada pertanyaan, komentar? Maybe not yet, Frauke.
Okay. So what we see here is that a lot of people who are having significant disorders, problems, are not in treatment, which doesn't mean that they never go into treatment. And for those, but also it means that also those who are currently in treatment might not have come to treatment at an early time or at a time when it started. So next to the treatment gap, the other problem in help seeking for mental problems are treatment delays. We had seen that already with the generalized anxiety disorders. And this is a study that I've found for Indonesia, a study published in English. It might be more in Bahasa, but I wouldn't find them. And this is from Bali, where they were able to assess 54 of 58 consecutive patients to a psychiatric hospital that were treated for the first time. So they excluded patients with a prior psychiatric treatment to really get an idea about the delays of first pathways to care for mental problems. It was about an equal share of males and females with a mean age around 30. The majority were Balinese and Hindu, only one was Javanese and Muslim. 30 of them, so the majority, were single, one divorced, one widowed, married, and one divorced, one widowed, and 21 were single. They had a mean education of 7.1 years, so rather low mean education, slightly lower than that of the family members. Some of them, 9 had a family history of psychosis, and actually the majority of those who were coming for help and included in this study were having psychotic disorders. Only 8 had affective disorders. 3 were given as neurotic, so this here would be like stress-related disorders, anxiety disorders, or obsessive compulsive disorders, and 2 had developmental disorders, that would be, for example, autism. Despite only 40 having a schizophrenic spectrum psychosis, 43 outcome was psychotic symptoms, and 17, so a third of them, were actually coming for somatic complaints like headaches and palpitation. So when we looked at their pathway to care, the majority were actually first seeking help with a traditional healer, who would then, after a while, refer them to the psychiatric services. Very few contacted a general practitioner or a hospital doctor or a community center. And it was only 4 that came to the psychiatric service directly, all of them being persons with psychosis. Overall, the assessed delay between first symptoms and first attendance in the psychiatric service was about half a year. This is actually quite a good number, and it was varying between 2 days for a person with an acute psychotic episode, so a psychotic episode that really starts with positive symptoms, and more than 10 years for a person with dysthymia. And the main interval, so not the medium interval, the mean interval before onset of first symptoms and going to the psychiatric service, was about 1.5 years. And when they looked at the interval before the first source of treatment and hospital attendance in week, then it was shown that going to a traditional healer first significantly delayed referral to a psychiatric service. There it was a delay of 19 weeks, so something like 5 months, while when they had been seeking help with a general practitioner, a hospital doctor, or a community health center, then it was only 2.5 weeks. So significantly lower delay. This was not influenced by a delay in first help seeking. So when they looked on the time between onset of symptoms and either contacting one of the medical agencies or a traditional healer, there was no difference. So people went to the first contact in comparable times, but the delay was here with a traditional healer, which means that likely, like in other countries where traditional healers play a huge role, that this likely points towards kind of bringing traditional healers closer to the mental health services, educate them more, and to seek more cooperation with them so that they can better assess where they might help or where they in fact might hurt by delaying. When we look at a disorder where I think duration of the untreated illness is very well researched, and that is psychosis, then we see that the delays in treatment are quite significant, that a significant proportion of persons had a long duration of untreated psychosis. This here is in weeks. There was one study that I found from Indonesia, from Aceh. I don't know whether I pronounced that correctly, where in line with these numbers, the duration of untreated psychosis still ranged from 2 months to 16 years. So a large variety of difference, and a huge proportion of delays. Unfortunately, the publication didn't give like a mean number for the delay in treatment for psychosis, so it's not directly comparable to that numbers. And this is what such a delay might cause. That is a recent meta-analysis on the duration of untreated psychosis and outcome. And what is here in the negative side, in fact, is negative. And what we see here is that generally such a delay in treatment is significantly related to the general symptomatic outcome. So this is in terms of a lesser remission or longer duration until remission of positive symptoms and of negative symptoms, with more hospital treatments, a lower social functioning, a lower employment rate, it's significantly lower global outcome. So this would be measured then with a global assessment of functioning that takes in the level of functioning as well as symptoms, a lower quality of life, and a lower remission rate. And if you think about what we have seen yesterday in terms of the per capita cost of psychosis, then this is well a significant contributor to that people tend to take a chronic course, probably to never start working in their life, because psychosis oftentimes strike on the shift from adolescence to adulthood, so they never really become independent and a contributing member of society. They need more treatment, they need more support, and so in that, the duration of untreated psychosis much contributes to the overall burden of the disease. And in fact, it is, for example, it's generally thought that when psychosis starts in children and adolescents, so before the year of 18, then they might take these psychosis might take a poorer course with more chronification, with less remission. And there is a study from Australia that could show that if you take in duration of untreated psychosis and you account for that, and generally the duration of untreated psychosis is much longer in children, adolescents than in adults. If you account for that, then the outcome is not different. So that means that, for example, with this disorder, that the reason why generally psychosis that starts in childhood take a poorer course is possibly mainly due to a longer duration of it's not being treated, and it's not like an inherent characteristic of the disease itself. So it's more like man-made, but not a part of the disorder. So with that, I think it's then important to look why help for mental problems is not sought at all, or why it is generally often only sought with significant delays. But before we go there, are there problems with relation to what we have seen so far? Questions, comments?
Frauke, there is one question here from participant, from Pak Ihsan Ansyari Anwar. The question is, he found that some people may leave treatment or medication in the middle of the course. And he found so many cases in social media, like there is a support group for psychotic or so on. Did that? What do you think about that? Why people leave the treatment or medication?
I think oftentimes they leave treatment because they feel it's not sufficiently working, or the other way around, that they feel they are already well enough, even if the clinician wouldn't support that. For example, with some medication, you would advise to give the medication even for a longer time to prevent relapse, to stabilize sufficiently, and not to stop treatment like with a headache the minute you feel that the symptoms have become better. And that this is oftentimes something that persons struggle to understand, and that they feel, oh, now I'm well and I don't need treatment anymore. And this might well also be related to things that we come to next, to mental health literacy, to stigma also, because taking psychopharmacological medication or going to a psychotherapy means you are treated for a mental problem. And that might, and with that, if you don't want to be a psychiatric patient or a patient for mental problems, because you feel that might be stigmatizing, or maybe because you stigmatize yourself, then of course you have a high wish to discontinue treatment for the very reason of not being a psychiatric patient anymore. And this is oftentimes what we find. And of course, with psychopharmacological medication, some people simply discontinue because of side effects.
Yeah. And in low and middle income country, I will add some question from this topic. Do you think in low and middle country the fee to pay for a psychological treatment is one of the barrier for the patient to come to get medication?
Certainly,
Mm-hmm.
certainly, or even long ways to go there. Yeah, for example, in one of the publication of the reason of Aceh, is that correctly pronounced?
Yeah.
Aceh.
And what's that? Uh, what do you mean?
That the region in Indonesia that is spelled ACEH.
Aceh. Oh, that's a
Aceh.
traditional healer, right?
And for example, in one of the in one of the publication from these regions, I
Oh,
had read
sorry, it's Aceh.
Aceh.
Yeah,
Aceh.
right.
Okay.
One province in Indonesia.
Aceh.
Yeah.
That some rural regions have so poor provision of services that people have to travel like 16 hours.
Yeah.
Yeah. And imagine you would have to travel 16 hours to go to an appointment. Of course, that starts then to be impossible.
Yeah. And Frauke, we still have one question. Do you want to continue the lecture or we?
No, I
Okay.
think it's best if you kind of have the question with the topic.
All right. So the second question is from Pak Samsul Arifin. He asks, as you explained that delayed treatment will be worse than the mental illness. If we take the Balinese case, Balinese is
Yeah.
a culture and a region in Indonesia. Is that because of the religious value influence this of the delayed treatment? So people come to traditional healer first, not to GP, or is that merely because their low education and low education? I think refers to low mental health literacy.
I think again, it's a mixture. For example, you'll find the same things in Africa, where most people are Christians, but nevertheless, traditional healers have no link to Christianity and to the religion, are still having a sufficient contribution in the society. So I think, especially with that, there might be links to religion, but I think it's more links to culture, irrespective of religion just being a part of it. And then, of course, it is again, I think sometimes a problem of what can be reached. If the traditional healer is there right next in the neighborhood, it's far easier to reach than travel far where you possibly even don't know what type of services exist and where to find them. So just simply knowing what service provision you might be able to get. Then possibly with the payment, but I think in Indonesia you have a national health insurance. Is that correct?
Yeah, but it's for an emergency case like a psychotic one. It doesn't cover for depression
Okay.
and anxiety disorder and common mental illness.
Okay. So it's not for all mental disorders and not for all mental health treatments.
Yeah.
Okay. Then I think, of course, generally, if you have a low education, you also have little money. That commonly links is closely linked together. So this kind of adds to the problem. And then, of course, you might not even recognize that you have a mental problem. In some of the publications from Indonesia, because in preparing that, I tried to read as much on these topics from Indonesia as I could get. I read that sometimes the mental problems are not perceived as a problem of the person, but as a village disorder. I don't know this concept. It wasn't, unfortunately, it wasn't explained, but it seemed to lead to the perception that somehow the village is cursed, or that the whole community has done something wrong, rather than the person, him or herself, needs treatment.
Because the high stigma level in the community, usually people with a mental health condition refers to the bodily symptoms. Like they said, I'm not really well physically. In Indonesia, we even have the term of masuk angin, the condition when we cold and cough and so on, just to make up the mental condition to be more accepted by the community.
Yeah. But for example, this is even reported from Southern Europe. That the more you go south in Europe, the more frequently people with mental health problems actually present with physical problems.
Oh yeah.
So what we would call like somatization. Yeah. So they express have far higher somatization rates because they somehow cannot say I'm feeling well, or it's even not a culture in monitoring feeling, but rather monitoring functioning.
Yeah. Thank you, Frauke. Pak Samsul, do you want to ask more, or maybe other participants? Yeah. I think we can continue.
Okay. So obviously, there are a lot of barriers to help seeking for mental problems, and I think we would sit here until Germany's evening and your early morning next day if we would want to cover all, but at least we should we should have a little idea about it. So barriers can be found on various levels, on the person, him or herself, or political levels, or at structural levels. And for example, in political levels, that would be whether or not there is a mental health care act or mental health care laws. I think in Indonesia, the mental health care act was only made like 6 years ago in 2014, if I'm correct, or 14 or 16. Yeah. So it's rather new that Indonesia has a mental health care law. And then, of course, this reflects also on the healthcare systems that are installed. And for example, with mental health care acts, that they would guide like or play into structural discrimination, like regulations, for example, on employment. For example, in Germany, a mental illness is considered a handicap, and you can get handicapped points for that, especially if it's chronic. And employers are regulated by law to, especially large firms, to give a certain share of their jobs to people with a handicap. So that is regulated to avoid some discrimination of people with a handicap, no matter whether it's physical or mental. So things like that, especially also laws that guide such inclusion for handicapped people, that gives them rights, for example, for supported employment. These are all things that have to be done on a political level to be widespread within a region. And then, of course, it's influential how the healthcare system is then created, whether or not there is availability of healthcare insurances. For example, there are countries that have no obligate healthcare insurances. Then, of course, it's how many people are covered in these insurances. For example, in the US, you generally lose your good insurance the moment you lose your job. So you have little possibility to enroll in healthcare insurances if you have no job. And then what is actually covered by it? What are the obligatory insured disorders and what is not insured? For example, as we have just discussed, of course, for the global mental health in Indonesia, it is unfortunate that only psychosis and some mental problems are covered by the national health insurance. So that I don't know, are there possibilities to have like add-on private insurances that would also cover the rest? If so, that again would then, of course, discriminate people with a low income, because they likely couldn't afford that or wouldn't even know about that, depending on their mental health literacy. And then very close to that, other possible barriers that play into that is the cost coverage. That is, of course, very, very closely linked to the healthcare systems and the service availability. So here again, we have the coverage of mental health expenses. So that would only be partial in Indonesia, but also the coverage of more indirect costs, like, for example, how much coverage you get if you have to have a supported living, like in a residential home for people with mental illness. If, for example, pay is continued if you stay at home because you have to care for a person with a mental disorder. So coverages like that are closely linked to structural and political decisions. And then, of course, the service availability is a crucial point. How well there is a coverage of mental health professionals and services, how well they are known, how far away they are, whether or not they're really implemented in the community. For example, like the Headspace services, I think I had mentioned them shortly yesterday, where people from the age of 15 to 25 can just walk in. They're not linked to hospitals, so they're not in a hospital area, but generally in a shopping area, like a bar or a cafe, and they can walk in there and simply ask for someone to listen to their problems if they have one and to get further advice. And something like that, of course, can be very, very helpful for first information of what you might do with your problems, what someone knowledgeable, some professional would recommend to you to do. So this can also be very, very helpful for a person. And then, of course, for service availability or for the pathways to the services, the training and beliefs of potential referrers are very important, so that even people who might be sought for help by persons with a mental disorders, that they are well educated, that they kind of detect the warning signs of more significant mental disorders that really need professional treatment, and that they can give advice to the person to go there. For example, in Germany, that would often be general health practitioners, or in the UK, just by the structure, you wouldn't go to a psychiatrist or psychologist right away, but you would be obliged to first go to a general practitioner, who would then refer to where you need to go in any case. So they would need to be very well trained. But also when it comes to mental disorders, these are persons who give spiritual support in any case. So where people who feel like anxious or depressed, or feel that they have family problems or working problems, might turn to for advice. They, of course, also need to be educated so that they can recognize where they might not be sufficiently trained to provide support, but where it's not like a mild problem that they can solve with some advice, but where it's really a mental disorder that needs proper training. And then, of course, on the personal level, we have the community, the people with that the patient has contact or living close to them. So there is a public discrimination, like singling out people with mental disorders, locking them away. Our public stigmatization is negative stereotypes, like all people with mental disorders are dangerous or are mad and you can never trust them. That could be stereotypes like that. It's little mental health literacy in the community. Our community believes that stand in the way of recognizing, of seeking help for mental treatments. That would be like mental problems are part of curses, or of wrongdoing, or mental community beliefs that possibly psychiatric treatment or psychiatrists and psychologists cannot be trusted, mad themselves, and only therefore seek this profession. So community beliefs like that. And then, of course, on the level of the patient, him or herself, it's either it's a perceived public stigma, what they think, what others think. It's a self-stigmatization and shame. So self-stigmatization in brief is defined as applying stigmatizing attributes from the community to yourself because you feel you might be a mental health case. And it's a poor mental health literacy in the patient. It's general health beliefs, It's role models. For example, oftentimes with men, they think that they just have to pull themselves together, that they are not really strong men, that they don't fulfill their role if they give into emotions, because men are supposed to not be emotional. So role models like that can play into that as well. And then, of course, socio-demographic uh, factors like age or income and general education. So a lot of different things that can stand in the way of help seeking, and generally a number of them come together. And just to show you from a well-equipped country how poor often, even in nowadays times, the training of non-mental health professionals is about mental disorders. I like to show you a list of the 10 most frequent misperceptions of mental disorders in German general practitioners. So they would be like crucial point in referral to mental health services. And here you can see that oftentimes these misperceptions or fallacies are not very different from the general populations, even though these are people who have been trained as a medical doctor, and even though this training also includes at least some learning about psychiatric disorders. And so here they often think that mental problems are caused by weak, ill, or indisciplines, or by mistakes in child rearing, like over spoiling, over protection, that mental disorders were generally treated on the couch. So just thinking about psychoanalysis when thinking about treatment for mental disorders, that they only have schizophrenia in mind as a mental disorders and don't think about others, that they think that people with mental problems would just have to pull themselves together and shouldn't act up, that they fear of prescribing psychopharmacology medication because they perceive that it might lead to addiction, which of course it's only true for some of the medication, like benzodiazepines, that they think that persons who talk about suicide will never do it, that mental disorders can either be treated with medication or psychotherapy, but not both at the same time, that only sleeping pills help with sleeping problems, and that ADHD, so attention deficit hyperactivity disorder, can only be found in children, adolescents, or even that alcoholics can learn to control their drinking, so that they don't have to stay away from alcohol if they ever had an alcohol dependence for their lives, but that they could learn like becoming normal drinkers. So you can find misperceptions on all different levels, but of course it's mainly studied in the general public. And here I brought you two examples from low middle income countries, one from Rwanda and one from the Philippines, where the structure of, or the availability of mental health might be a little bit more in line with in Indonesia. And here we see again that there are these structural barriers. It was too far away, like the one that was also partly responsible in Aceh. Oh,
Aceh.
Aceh.
Yeah.
That there was, if it's far away, that there was no transport available, that they could not afford transport or the costs for the treatment, or that they would have no insurance. So this was reasons that was frequently named, and then barriers related to knowledge and attitudes, that they didn't know where to go for treatment, that they were from their culture too embarrassed to discuss mental problems, that they didn't believe that they could receive treatment for that, that they should be able to care for them, for the problem by themselves, that it might be disappearing just as it occurred, that they didn't know what would be done to them if they go somewhere, what are the treatments, the tests, whether they probably even would get a brain operation or something like that, that they simply didn't want any help, that they went to other sources for help, or that they felt they couldn't afford to go away because they had people depending on them. And then in terms of stigma-related barriers, it was that they were that was rather low in Rwanda, that they were afraid that someone would see them at the clinic and would know that they have mental problems, that they would be ashamed that people would know they were troubled by mental problems, and that they were afraid that the family could know about it, or that they had general concerns about confidentiality of what they report there, so that they were afraid that this stuff might actually report it. But in summary, the main reasons here were actually the structural barriers and the barriers here related to knowledge and attitudes. And this was somehow equal, somehow different in a study from the Philippines, and they studied Filipinos that were living in the Philippines, as well as Filipinos that were living overseas. And here again, a huge contribution to barriers in help seeking here was financial constraints, or that they couldn't find a service, or didn't find it accessible in terms of transportations or else. But here they mixed this a little bit, and for example, with the financial constraints were not only fears about not being able to pay for the treatment, but it was also like stigma related financial constraints, for example, that they were fearing of losing their job if someone would knew that they were seeking help for mental problems, So a kind of mixture, so stigma-related fears about losing their income. And then in terms of social cultural barriers, there was a huge proportion who perceived the social stigma as a huge barrier, not only a social stigma that would act negatively on them, but also to the family's reputation. As this also includes fears of being negatively stereotyped, like labeled as crazy. Then there was a sense of religious and for example, that they preferred to ask spiritual persons to help them, that they felt like praying should be enough to alleviate the symptoms, that God would help them. In few of them, it was difficulties with the language. I don't know if that could be any kind of problem in Indonesia, if there are different dialects spoken, or if there is like a well-spoken national Bahasa that all people speak because it's so long stretching. But if there are different dialects, of course, if someone moves, it could also be a problem to find someone who's speaking the same language and can help. Then an adherence to Asian cultural values of conformity, that you have to function, that you have to be like the others, were also something that was by them mentioned by 33%. The use of alternative health care, like traditional healers, that was lower in this study group. And then there were the psychosocial areas like self-stigma, here in particular a concern for losing the face, embarrassment, fear of negative reactions from friends or family, a feeling that there be a disgrace or self-blame for so holding oneself responsible for the mental problems. That was a huge share. Then preferences of the families, advice of friends played a large role. If they, for example, advised them not to go to a mental health service. And in fact, we had that once in our service in Bern, where a young Filipino presented who had already suffering from a psychotic disorder. And he presented at our service because he felt that he needed mental health, despite his family that was absolutely convinced that he had been cursed, that nothing was wrong with him, and who would have actually preferred to take him to the Philippines to a traditional healer who could alleviate the curse. So he luckily, despite the family's advice, came to us and actually responded quite well to the treatment. But his family, if it has been to his family, he wouldn't have come to us at all, but he would have been treated for being cursed. And then also, as in Rwanda, concerns of confidentiality, privacy, fears with treatment, then also like lack of awareness of mental health needs. So normalization of mental problems, or everyone feels sad from time to time, or everyone is anxious from time to time, or even like normalizing the mental problems. Or misconceptions about the mental illness, about the nature and causes, or a sense of self-reliance, that the feeling that you are fit enough, that I'm well equipped to deal with that themselves. And but this was only a low contribution, as low as fear of hurting or becoming a burden to others. So a large variety of attitudes and knowledges that can contribute here, and often leading also to a decrease in the perceived need for help, so that you would not think that you actually need help, that you think you're not a weirdo, that you're afraid of confidentiality, that help is too far away, that people even start to self-medicate or feel that they problems are like a deserved punishment, or that they can deal with it themselves. So a huge variety of different reasons that can lead people to not seek help, or to be ashamed about seeking help. Are there questions, comments?
Yeah, there are questions in the chat box, but before I go there, I want to make my own comment on the result of the research from Rwanda and Filipino, I think. Philippines. Yeah. What do you think about the attitudes of mental health care workers? I mean, we usually try to investigate about the public stigma, the lay people attitudes toward mental health, but a little research on the attitude of mental health care worker. But I think it's quite important, because sometimes people may be fears to come to the healthcare provider just because they're afraid they will be stigmatized by even the worker over there. Do you have maybe a reference for that?
Yeah, they are. You are absolutely right that there are little research on that. Some research that had been done by the WHO, and I'm aware of one study in Switzerland that had compared the stereotypes about mental disorders from the community and from mental health professionals, and they had found that the mental health professionals had even more negative stereotypes about people with mental illness, so they would trust them less. They would have a more a negative view on their outcome, so they would think of them even more as incurable, and they, in terms of questions like would you have someone who had mental disorders looking after your children, they were even more reluctant to answer that positively.
Yeah.
And what they also found was that mental health professionals were less open to alternative views. Yeah, so it was far harder to change these negative perception in them than with education, than in the general population, who were far more open to taking in new information, and that was simply because the mental health professionals were quite sure that they didn't need information, that they knew by their profession and that they were right. So they were not far less open to change this negative stereotypes.
Yeah, what a challenge for the. So the question, I read some question in the chat box. The first one from Ernestine. She asked, ADHD in adults are dismissed as someone who is too lazy to do things properly. How to educate the general people about the importance of differentiating ADHD as neurodivergent situation, not merely a behavior problem like laziness.
I think that is with all mental problems, the best way to educate and avoiding stigma, because we will see that sometimes education might increase even stigma, unfortunately, is like personal contact, that you educate on a person, that you present like a person with his problems, so that people can really also experience as a person like themselves, and not only as someone different. Yeah, this is me and I am different from the person with a mental disorder. Yeah, so not as to treat them like someone of a different, let's say, race. Yeah. So this is certainly quite important. And then, of course, it would also be important maybe to educate in schools, because you don't develop an ADHD in adulthood, but it would be there in school. And of course, the best thing would be if schools and teachers would be educated sufficiently about that, because that would be like the situation, of course, when ADHD would show first, and you would have like a clear target group for education that could then send pupils where they think that they might suffer from that for further evaluation. But I think especially for ADHD, school programs educating teachers would be a good target.
Yeah. Yeah, Ernestine, do you want to add some more questions? Okay, we can continue to the next question from Frida Rufina. The question is, what can be done to minimize toxic masculinity, especially when it's associated with help-seeking behavior? He still encountered this around him. Example, even from young age, boys are told not to cry.
Yeah.
And this can be a problem for men to find proper help. Do you have any comment on that?
I think this is really, really tricky.
Yeah.
Like all general changes, and certainly also relates to the culture in the background. Yeah, for example, in Europe, we have great differences from the north to south in the perception of man.
Oh.
Yeah, like in Spain, and in South Italy, there is not much more like the machismo, like the strong male that don't cry and has a clear idea how men act. While the more you come to the north, the more the expectations on behavior of men and women equalize. Yeah, so that it's okay, and that boys are explicitly told it's okay to cry, it's okay to be sad, it's okay to show emotions. But that is only a thing that is happening, I think since the 1950s onwards. So starting in the 1960s, before that there were very clear cliches, and it's only slowly emerging, but it's always placed together with emancipation of women, because it's only if it's like you would allow males to behave more female, to be closer to their emotions, and to better deal with them. But that only goes together if you also allow females to more act like men, to be more independent, to go their own ways, and so that you equalize the sexes in rights and expectations.
Yeah, related to that question, there is a link between collectivism culture and individualistic one that maybe impact on the value that society have in individualistic culture? Then you need to be your own, and then women and men think they should be comparable. And in collectivistic culture, we will be like children will be raised together, especially for the female one. Do you think the culture of collectivistic and individualistic influence on that?
I think not necessarily, because if you look for example, to China,
Oh yeah.
Which has a rather collectivistic attitude, but the expectations, especially due to the communistic viewpoint, were like the same. They should both work, both genders should equally contribute to the society, and share their roles. So I think it's not necessarily so that the equality and equal perception of men and women and lesser gender roles are related to individualism versus collectivism.
Okay. Oh, some questions arise. So the next one is from Patmedia. Increasing mental health literacy are urgently needed at all levels of education, and she wants to know more about the implementation of mental health literacy program in German, if you have any information on that.
There are some general ones, like in newspapers and in public campaigns, often targeting particular mental problems. Very frequently, it's depression, because it's the most common one. I think it's generally more of a topic, also like in how do you call that, soap operas, like these daily soaps in the television, where you follow, like you have daily episodes on a certain bunch of people.
In Indonesia we call it as sinetron. Sinetron, Bapak Ibu, dimasukkan dalam sinetron.
Okay. And for example, mental problems of all kinds are a topic in there as well, contributing to psychoeducation. A general problem with psychoeducation is that those who generally need it most, that's lower educated, commonly don't get their information, or less and less get their information from, let's say, good sources like newspapers, but that they rely oftentimes to the internet, to chat rooms, to WhatsApp groups or something like that. So to poor courses that also contribute a lot of, frankly spoken, bullshit about mental disorders. So those are the groups that you rarely reach. So in the long run, I think, again, the best would be to implement such protocols or information in schools, because there you could then reach like everyone. And of course, you would reach then people in an age group where they could most profit from it. Yeah, if you are 50-year-olds and you've suffered, let's say, from depression since 30 years, and then you get some education that your problems are actually worth treating, it's okay if you get treatment in the end, but it would have been better if you have recognized it before. And as we had seen yesterday also with the disability adjusted life years, it's a growing problem over childhood and adolescence. So a lot of mental problems start there. And for that reason, it's very important to educate the children, who could then also take their knowledge to the families. If they come from school, and then if they talk about things like that, what they have learned. And so there are school programs like that, but not in a regular base. And actually, it's a huge criticism of medicine and mental health professionals as well, that in German schools, and that's is common with a lot of countries in Europe, you don't have health education. Yeah, you learn about how a bee is functioning in biology, or about a lot of different things, but you don't learn about your own health and your own health protection. And that is the case with many of the common somatic disorders, but also with mental disorders. But it's a common agreement that school, in the long run, would be again the best way to educate equally a large share of persons.
Okay. So the next question is from Dian Wahyu. How can we convince or help to raise the help-seeking behavior on people who we know that they have mental health problem, but they don't realize or don't want to realize that they have problem? Also, for people who knows that they have problem, but they don't want to get treatment, and they keep it for themselves. Yeah.
I think the first thing is to really do large studies where you don't only look at single correlations of single items with help seeking, but where you can also detect how these problems are intercorrelated. So that you can detect like good targets from that other problems in help seeking or other barriers in help seeking spread, and that you can then develop like a community appropriate or country appropriate ways to overcome that. Yeah, for example, to and maybe have like different programs, yeah, targeting different things. Like for example, in the Western countries, and come to that in the next sections, when a lot of education was focusing on presenting mental health problems like a problem like everything else, so like a problem with the brain, like more organic. A lot of education in the 1990s is in particular went to that in an approach to normalize it. And now it becomes more and more clear that even though this increases mental health literacy, and in a way also increases help seeking, that unfortunately it also increases stigma. Because someone with a different brain, again, is different. And then this organic perception of mental disorders then makes other people so different to the core, and of course is again often then perceived as something that is not really treatable completely.
All right. So at individual level, for example, if I have relatives or family member that I know they have some mental health condition, but they do not want to ask for help, what do I need to do if I am a lay people?
That really depends on the problem. For example, when you have someone with psychosis who has a mental problem where a lack of insight is a part of the problem, and not realizing that, then of course you have to take a completely different approach if someone is already fully psychotic. And for example, with someone with a depression, who might who will still feel that something is wrong with him. And while, for example, with someone with a psychosis, you probably have to look for outside help, and if, in the worst case, for involuntary treatment. With someone with depression, you should try to install hope, because, for example, with depression, a feature of depression is that you perceive that everything goes wrong in the future. There is a negative future. So certainly then also the perception of treatment outcome would be tainted. Yeah. So that someone with depression could easily think in its line with everything will go wrong and nothing will help. This negative perception, of course, could be also applied on the treatment, and there you might have to try to say, well, please, just for me, try it. Yeah. So to go more on a personal level, and to try to bring them to help, so that maybe just saying, well, try it. Yeah. If someone is anxious, then of course facing a new situation will raise anxieties, and that you educate or say, well, let's go together. I'm on your side. I'm with you.
All right.
So to lower the threshold.
There is a question from Ernestine that related to the ADHD case. She already asked before. When you mentioned about the education on ADHD from school, Ernestine think that there is a psychology course in the US, but not in Indonesia. So the question is, when there are no support from the curriculum or from the government to promote mental health, especially in the school, what can we do?
For example, in Germany, there are special health, little healthcare courses that have been designed to fit like into every school, and you can go to schools and promote that, saying, well, give me like 6 lessons of your biology lessons. Or if you have, for example, our schools sometimes have like a practice week where they have not the regular lectures, but where they have projects. Yeah, and for example, dedicate such a project week to mental health. And they or things that where you can also have like homeworks. For example, one of these packages that you can lend to schools and offer them, that they ask the pupils to make surveys on the street, like as homework. Interview people on the street, what they know and what they think about mental illness. And it is then like discussed in the classroom to start talking about stigma and to reflect that and to correct wrong perceptions. And then in the next step, they, for example, ask as homework to not only ask people what they think, but to argue a little bit with people on the street. Yeah, and that is like a very nice and active way to involve them actually in anti-stigma behavior. At the same time, educating them about mental illness and what to do.
Okay, I think that's all the question from now, and we can go on to the presentation.
Okay. And with that, we come actually to the mental health literacy. And here, this is a study from Indonesia where they ask 16 to 18-year-olds what they know about mental health or mental ill health. And there was quite a general perception of good mental health that was conceptualizing it as emotional well-being and happiness. So quite in line with the well-being, the psychological and subjective well-being that we have heard about yesterday from Ruth and Dinah. And the poor mental health was predominantly described in terms of behavioral changes, like inability to cope with stressors, poor social skills, fractured or absent social relationship, or in males that they would act violence, or in females that they would harm themselves, or in terms of physical aberrations or disturbances that you look actually different, like being heavily tattooed, malnourished, dirty, have a pale face, be skinny, having red eyes, or not being well groomed. What was striking in this responses of these adolescents was that very common symptoms of poor mental health, like feeling stressed out, loneliness, poor sleep, or of common mental disorders, and particularly like depressiveness and anxiety were more or less absent from the descriptions, indicating that these symptoms might in fact not be recognized as signaling a mental health or a poor mental health, a significant mental health problem. So for example, if I think this was not including Java, so in fact, like getting informations like that, you could generate targets where to focus your education on. In this case, in this area, certainly educating about depression, anxiety, stress, loneliness, or sleeping problems, a sign of mental illness, would be a first starting point. And then another thing that they took from the descriptions was that there was obviously the perception that poor mental health would only happen to other people, which was accompanied by a lot of stigmatizing views, and that a conceptualization of poor mental health as something that is like a normal human experience that can like happen to everyone. If we think about the WHO prevalences of every second person once in their life having significant mental health problems. This was absent. So this might be something, if that is also within your region, something that is common, that would be something to educate as well. What was interesting was that when they were asked about determinants of mental health, that they actually knew about a very large variety of potential risk factors. So in this, there was a good reflection of the perception of various risk factors at play in, for example, in the community, like stigmatizing cultural belief, lack of community engagement, but also with the social media, like cyberbullying, a lack of spirituality or faith was mentioned. Then pressures in school, being poor student-teacher relationship or little structure in school, over burden of workload, bullying, harassment, mobbing, or in the family, parental pressure, broken homes, family dysfunction, and then poor social relationship, and in the individual, like a low self-esteem, lack of confidence, antisocial behavior. Interestingly, what was absent here was like the biology, that mental disorders can also have biological courses, which of course would also affect willingness to receive more or to take more biological prone treatments like medication. And on the other hand, like the protective factors were equally great, with a good social support, a good spirituality, positive surrounding in school, in the family, a good relation with friends. And then interestingly, and there was no indication that that was different between boys and girls, the ability to express feelings and emotions, so good insight, being in tune with yourself, socializing with friends, sufficient rest, exercise, and good diet. So quite a lot of things these adolescents already knew, but also quite some things that they wouldn't know, and where they could be educated about. And I think such knowledge about what is there and what is absent, what beliefs are wrong, and what beliefs are already implemented in a community are quite important to be assessed initially, and then again reassessed in order to adjust awareness campaigns, so that you don't educate like about things that they already know, but that you really kind of make sure that you educate about the things that are needed to be known. And as I said, I would come back a little bit more also to our study in Bern, where we had not only assessed mental health problems and pathways to care, but also mental health literacy and stigma. This was done with a questionnaire that was as well established in the German region and has been used several times in German-speaking countries. And in this first an analysis here that is currently under review, we looked how mental health literacy, in particular causal explanatory models of mental health, would relate to stigmatizing attitudes, in particular to the wish for social distance. So wish for social distance would include that you would say, well, I wouldn't have someone with a mental illness looking after my children. I wouldn't recommend someone with that for a job. I wouldn't want someone like that as my neighbor. So everything that distance yourself and your private sphere from people with mental disorders. And what we found here, and I think, oops, this needs a little bit explaining. As a correct labeling, we had like 2 vignettes depicting in one case a psychosis, in the other case a person with a depression, without saying what disorder was depicted. So the first question for mental health literacy was, what are these, what is this person suffering from? And whenever in case of the psychosis vignette, someone says something like psychosis or schizophrenia, or would term the positive symptoms correctly, like delusions and hallucinations, we would say that is a correct labeling. And in terms of the depressive vignette, we would say, well, this is everything that says, well, it's depression, it's depressiveness, consistent sadness. We would see that as a correct label. So what the first finding that we had here was that certainly there was a higher correct recognition of the depression vignette. So from what I've learned about Indonesia, I wouldn't necessarily expect that to be true in Indonesia. And that it was rather the psychosis vignette that was oftentimes not correctly labeled. Whenever something was correctly labeled, or in case of the psychosis vignette, then a biogenetic explanatory model as so relating the disorder to biological reasons, genetic or biological reasons, was more common. Psychosocial stress as a reason was more frequently assumed when there was no correct labeling, so with a kind of lower mental health literacy, and when the vignette was of a depression. And that was also related to an explanatory model that was related to the constitution or personality of the person. Interestingly, none of these explanatory models and also not the correct labeling, so the mental health literacy itself, had any direct influence on the wish for social distance. So this was unexpected, because we would have thought that good mental health literacy would reduce the wish for social distance, which was not the case. Rather, the stereotype as a part of a stigmatization, so the perceived characteristics of patients, that was what had an influence on the wish for social distance. So here, perceiving someone as dangerous, unpredictable, increased the wish for social distance, and that was significantly increased when the mental disorders was perceived as caused by genetic or biological factors or by the constitution and personality. So when it was perceived as something where the cause is within the patient. And it was only psychological stress when that was perceived as an explanatory model. That was the only thing that reduced the wish for social distance, likely because psychosocial stress is perceived as something that can happen to everyone, or where people can kind of familiarize with, they can relate to. So this, in line with other recent research, was actually calling to caution to relate too much on biogenetic models in awareness campaigns, but to at least balance the presentation of psychosocial stressors, or to even emphasize psychosocial stressors that always play a role in the onset, at least, a little bit more. And just to show you what kind of questions were lying behind these factors of causal models, here psychosocial stress would be questions: how much is it work related due to too high self-expectations, problems in the family, daily hassles, stressful life events, or unconscious conflicts. Substance abuse was not shown here because it didn't play a role, a significant. A constitution and a personality was with questions that they have a weak will, a weak constitution, an immoral lifestyle, or even that it was God's will that they would become ill. And then, interestingly, childhood adversities other than current psychosocial stressors also played not a significant role in the model, but biogenetics would have been like that they had inherited the problem, or that it was a brain disease. And the same for the stereotypes. Here, the dangerous, unpredictable would be affirming that this person in the vignette was dangerous, lacking self-control, being frightening to others, being unpredictable, aggressive, or strange. And the other factor, the dependent and needy factor, would be that the person in the vignette would be perceived as dependent on others, helpless, and needy. A little bit of a downsize in this questionnaire, I think, is, for example, with the stereotypes, they present always negative items. So you can't really, where you have to disagree with. And I think a good questionnaire should also present positive attitudes, like being very reliable, a very nice person, a very sensitive person, for example, to see whether such negative stereotypes are sometimes also counteracted by, let's say, more positive ones. So in this study, and I think it's one of the few that has generated like a more complicated interaction of contributors between mental health literacy and stigma. As I said, it was striking that mental health, in terms of correctly recognizing a disorder, did not directly influence the wish for social distance, but that it was stereotypes whereby the biological causal models increased negative stereotypes and thereby the wish for social distance. Good mental health in turn increased likeliness of endorsing biological causal models, so likely also via two indirect paths, increasing the wish for social distance, and therefore that mental health campaigns based on the medical model, such as a frequent mental illness is an illness like any other approaches like this, run the risk of unintended consequences in terms of an increase in wish for social distance. And another interesting finding was that there's often a debate of whether behaviors and symptoms or label form the basis of stigma. For example, based on the assumption that labels are the basis of stigma, they had renamed schizophrenia in Japan. But our results would indicate that the major stigmatization actually comes with the behaviors and symptoms, because it was the vignette that had an influence, but not the correct recognition. So it wouldn't matter whether someone realized the schizophrenia vignette as a schizophrenia vignette. It was psychosis, the vignette itself, that has risen a higher stigma than the depressive vignette. We don't have much time, so I would continue and not ask for question at this point, but rather see that I'm going quickly through the rest so that we have some questions in the end. Is that okay?
Yeah, you can go on.
So when we look at stigma and help seeking, this is the results from a meta-analysis of a former colleague of mine, Nina Schnieder, and she had looked not only at help-seeking intentions, but at active help-seeking in the general population and stigma, and conducted a meta-analysis of that, and quickly summarize what was interesting here, that of course stigma had a decreasing effect on help seeking, but it was generally the stigma of the person or stigmatizing attitude of the person himself, and not the perceived public stigma. So the perception of what others think had little influence on help seeking, but it was what the persons themselves were thinking, what influenced their help-seeking behavior. Of course, certainly your own perceptions will be influenced by what people in the surroundings think of you, but in these studies, unfortunately, mainly studies again found in Western countries. It was mainly the as expected self-stigma, the personal stigma or attitudes towards people with mental illness, and general help-seeking attitudes, what people would expect would come out of help-seeking, whether, for example, they would expect that they could be perceiving sufficient help and meeting sufficiently professional mental health worker on the other side. I could or would assume that possibly the perceived public stigma might play a larger role in countries where there is more pressure on conformity, where you are more concerned about what other people think of you or your family. In our study, again, when we looked at mental health literacy here in terms of these causal explanations and stigma, and their effect on healthcare utilization. We found like two pathways. One was a negative one, where in particular, again, biogenetic and constitutional causal explanation, again, increased the perception of the person as unpredictable and dangerous, increased the wish for social distance, like in the other model, and thereby decreased the healthcare utilization, so decreased help seeking. And then there was a positive one that mainly went from perceiving psychosocial symptoms and not a characteristics of the patient. That was related to perceiving help as more pleasant and less embarrassing, increased the help-seeking intentions, and thereby increased also active help-seeking. But you can see here also that if you only ask about would you seek help, so help-seeking intentions are by far not the same as actually seeking help. So more studies should focus on actual help-seeking rather than just help-seeking intentions. So this would reconfirm that especially the education about psychosocial stress and how that can be reduced with help of mental health professionals might increase help-seeking behavior. For the course of time, I switch over the little differences between the depressive and the schizophrenia vignette. But just in short, the negative stereotypes played a far greater role in case of the psychotic vignette. And the biogenetical causal models only played an insignificant role in depressive symptoms, reconfirming what we have seen before, that particularly psychosis increases a biogenetic causal models. When we recently looked at prospective help seeking, interestingly, and this is only the significant pathways, we found that prospectively the wish for social distance had little direct influence on the help seeking 3 years after. This was mainly in the first model that I had shown you on help seeking, influenced again by functional deficit. If there was significant functional deficit, help seeking was more likely. So the same as in the first model. Also help seeking to seek help positively. And here we had also assessed attitudes about help seeking, and help seeking was reduced if you felt ashamed about it. Public stigma, as in the meta-analysis, had no significant increase. When we took out the help seeking at baseline, what remained was the functional deficit. So this actually played a very, very important role, and maybe in awareness campaigns could be more taken in the foreground, that you say, well, if you feel that you have difficulties in performing your role, if you withdraw, if you have difficulties at your work, maybe that's something where you should seek help. And the embarrassment about help seeking, that were the main influential pathways on help seeking prospectively. So indicating that especially poor functioning should be targeted, and that help seeking for mental problems should be more normalized. So this is just the summary again. So again, functional deficits are important. Shame is important. While the wish for social distance here showed only an indirect effect. But certainly all these models will change if you take in, for example, knowledge about treatment. This is still something that we have to be done, but it signals that certainly we need much more studies on that. And one study on mental health literacy and stigma has been conducted from one of your colleagues. And it was a door-to-door survey by trained assessors. It used a 40-item community attitudes towards mental illness scale that comes in 4 subscales, where higher authoritarianism and higher community mental health ideology indicates higher stigma, and lower benevolence and lower social restrictiveness indicates also a higher stigma, and a higher total score indicates less stigmatizing attitudes. And the other one was a mental health knowledge schedule with 6 items on stigma-related knowledge areas, where high scores indicate a greater knowledge. It was quite a large sample that was reported to be quite representative in terms of education and in terms of monthly income, with slightly higher percentages of females. Somewhat, if I say something incorrectly, please correct me. I think some of you will have participated in this study. When they looked at this correlation between age, it was showing that an older age correlated with more stigmatizing attitudes. That was also shown by the initiators of this screen, Dean and Taylor, and in many other countries. And it seemed that a higher score on stigma-related knowledge areas was related to more stigmatizing attitudes, because a higher score in the CAMI introduces less stigma, and it was a negative correlation, and that seems to be partly in line with a study in Ethiopia that has used the same scale, and who found that belief that mental illness can be cured was actually associated with a higher stigma, while the perception of supernatural, psychosocial, and biological causes was related to lower stigma. So here again, maybe a need for more in-depth studies what part of mental health literacy actually it works positive and what works negative on stigmatizing attitudes. And then from the socio-demographic correlates, that was quite in line with what you see from other countries. And here again, I particularly took out Ethiopia that has used that. So being married, which is equal to being older, increased stigma. Oftentimes in Western countries, we found that being married, which commonly goes together also with having children, also increases more fear of people with mental illness for fear of the family. So there's a more protective attitude once you have a family against people with a mental illness. Then interestingly, in the Indonesian study, it was the median incomes, so the lower middle incomes that had the highest stigmatizing attitudes, while those with a low income and with a particularly high income had lesser stigmatizing attitudes in Ethiopia, but they had lesser classes of income. There was a clear correlation, lower income, higher stigmatizing attitudes. And here again, education appeared to be unrelated to stigmatizing attitudes. Again, in the Ethiopian study, there was an inverse correlation, lower education, more stigmatizing attitudes. And then, as in the original publication of Taylor and Dean on the Kami, male sex was related to higher stigmatizing attitudes. That is something you find in Western countries as well. And interestingly, here, former contact with a mentally ill person or positive family history of mental disorders and a Pasung supported attitude were associated with it. I think that can be explained if you think about what is perceived as mental illness by the adolescents in Indonesia. Then you mainly have highly stigmatized behaviors like psychosis and looking differently. So everything that generally makes you perceivable as someone else as a mental illness. So possibly like the more normal mental problems, disorders like anxiety disorders and depression weren't perceived here as a mental disorder, and therefore it was really that this high stigmatization, even in the contact of people who had been perceived as mentally ill. And of course, and that's just briefly a very significant challenge that you still have in Indonesia is this Pasung, which is where the people with mental disorders, especially, I would think that it's frequently people with psychosis, with a very kind of alienating behavior, are chained or locked up for different time spans. And even though it's forbidden since the 1970s something, I think there are still ongoing reports of this practice, especially in rural countries. But luckily, if you get to these patients, if you educate the family, there seems to be a very good result that the majority of those having been found to be in Pasung can then be released. So it's not cruelty of the family, but rather often it's ill knowledge or impossibility to get other help, that they don't know what else to do to protect the patient or themselves, and who generally report to be very, very happy to receive other possibilities. But certainly this is not only the case in Indonesia. Similar forms of coercions have been found in the past in other countries, or even in different types in parts of Europe nowadays, like in Romania, where people with mental illness were kept in such bad conditions in like one hospital that they had an annual death rate of 10% by starving and freezing. I think that is not better than Pasung. So thank you. I can add a little bit more time if you can to ask more questions.
Yeah,
otherwise,
maybe
I'm
we can.
happy.
Wow, terima kasih atas perhatian Anda.
I have the translation.
Yes, more in bahasa. Okay, I think we can accommodate one question maybe from the participant. Is there any question? If there's no question, maybe Frauke, you can give a closing statement from the series on mental health courses for 2 days, for these 2 days.
Yeah. I think what we have seen is that indeed mental health problems are a significant problem, that they might not be increasing in number as often perceived by a growing number of people seeking help, but that this growing number actually is a good sign of more people coming into help. But nevertheless, that there is a lot to be done to educate the public, to educate those in charge. I mean, it's also a political work to ask the governments for more money, for more attention to mental problems, to give more support, to provide more services. It's certainly also a standing of mental health professionals, so often seem to be reluctant to promote their profession. So I think that should be done as well, because if you as a mental health professional are well perceived, then people will come much earlier. So I think there is a lot to be done. And I think this should also be very carefully rooted in good studies. So as we have seen, like what had happened in Europe with the mental health literacy awareness campaigns that had targeted the biological causes, that suddenly years after, what is seen is that not only stigma had not decreased, but its parts has even increased by that, even though if help seeking had increased. But of course, if we do something, we want to have both. We want to have increased help seeking, and we want to have decreased stigma. And we wouldn't want to weigh one with the others. And I think for that, we need careful studies that are well rooted in the present culture and pay respect to the different cultures, to different educational levels, also, or to different genders. So it might not be like one awareness campaign for all, but maybe different subgroups of the community need different awareness campaigns, and how to develop them and how to treat them, and what are these subgroups and what should be treated with them. I think that requires careful studies, but you are already on the way. to that.
Hopefully. Hopefully we are on the right track. Thank you very much, Frauke. I just
Thank
want
you.
to make a very short conclusion from this session that many factors contribute to the help-seeking behavior. This can be categorized as political, structured, and personal factors. And stigma can be a significant barrier of help-seeking behavior. And increasing mental health literacy is critical to support help-seeking behavior. I think that's all for today. Thank you very much, Frauke. Dan let me talk in bahasa to the participant. Bapak Ibu, terima kasih atas kehadirannya dan sampai sore ini jangan lupa untuk mengisi presensi karena nanti materinya akan kami berikan melalui email dan saya ingin berbagi informasi tentang beberapa kuliah umum yang masih akan berlangsung oleh Fakultas Psikologi UNER. Frauke, can you please stop sharing screen because I want to share something. Okay.
What is it? Wait, I can't.
Somewhere below the bar,
hidden.
I think.
Yeah, oh yeah, I had hidden it behind your pictures.
Yeah.
Okay.
All right, thank you. Jadi Bapak Ibu besok hari Jumat setengah 10 kita masih ada kuliah umum untuk kesiapan pembelajaran tatap muka di PAUD. Pembicaranya ada Direktur PAUD dari Dirjen PAUD Dikdasmen ya, ada Dr. Muhammad Hasbi dan nanti akan dipandu juga oleh Ibu Nur Aini, dosen dan juga Wakil Dekan 1 Fakultas Psikologi UNER, dimoderatori oleh Dr. Primatia Yogi. Kemudian di hari yang sama kita juga masih ada ini yang tidak kalah menarik untuk siang harinya. Kita ada kuliah umum tentang perilaku manusia dari perspektif neuroscience. Pembicaranya ada Galang Lufityanto PhD yang akan dimoderatori oleh Nido Dipowardana ya. Kemudian yang terakhir, yang tidak kalah menarik, adalah di hari Sabtu kita ada kuliah umum tentang pergulatan psikologis dan sosial mereka yang terjebak dalam jaringan terorisme. Pembicaranya ada Kepala Densus 88, kemudian ada dari Nur Huda Ismail PhD, ini adalah pengajar dari NTU, kemudian Pak Ilham dari Psikologi UNER, dan yang tidak kalah menarik akan menghadirkan Ustadz Abu Fida, mantan jihadis. Jadi kita akan mendengarkan dari beberapa perspektif. Demikian yang dapat saya sampaikan. Terima kasih untuk semua partisipan. Saya mohon maaf bila ada kekurangan dan kami undur diri dari panitia. Thank you very much, Frauke, for all of the session these 2 days, and hopefully we can shortly contact you to have maybe any other fruitful activities in the future.
I hope so.
Thank you very much.
Thank you, Jan.
And we have Bu Endang as well here. Maybe Bu Endang, you want to say hi?
Thank you,
or goodbye.
3 sessions, yeah?
Yeah. Oh yeah, right. 3 sessions.
It was a pleasure.
Yeah.
I learned a lot about Indonesia already, I feel.
Oh yeah. and yeah,
coming to Indonesia, yeah. So hopefully
yes,
we'll offer soon.
So you can visit Indonesia.
Now if best destinations are near, yes.
Yeah. Okay.
Okay, thank you very much.
Thank you.
Yeah.